Achievement Award from the American Sleep Disorders Association, and as well as a special award in sleep and psychiatry from the NSF. He is a distinguished fellow of the American Psychiatric Association, and he's authored 5 books and numerous peer-reviewed papers on various aspects of sleep research and psychiatry. His most recent publication, we are happy to have been talking about in our Awake page, and that it's Understanding Antidepressants and Understanding Sleeping Pills, both available on Amazon. His website describing his interests, a blog devoted to literature, as well as his CV, can be found at, we'll put the link up there for you, but it's zipbit.org. Welcome, Dr. Mendelson. Thank you so much for being here today.
Well, thanks, Teresa. It's very nice to be able to join you all today, and I've been looking forward to chatting with you about the consequences of insomnia. Next slide, please. I guess the main thought that I wanted to share with you today is that insomnia is not just a problem of lying in bed, unable to sleep, and all the difficulty at nighttime that we're all so familiar with. It's really a 24-hour-a-day concern. And the focus of what we're going to chat about today is the many, many ways that insomnia affects a person's daytime life. Now, a couple of these are very obvious and I'm sure are very familiar to you, like fatigue and just feeling out of sorts. But there's also some that are very surprising and that most folks aren't aware of. One that I think sort of led to Teresa and me originally being in recent contact had been some interesting studies that came up on the topic of insomnia and loneliness and insomnia and people's relationships with each other. And we're going to talk about those in detail in a couple minutes. Others that come up are folks with insomnia have lower scores on measures of quality of life. They have more absenteeism at work and poorer job performance in general. One of the ways this really came home to me when I was a young sleep researcher was a study that was done on Navy recruits in San Diego area. And what they found was that on the enlistment physical and health assessment, there was a questionnaire that happened to include questions about sleep. And the doctor who was doing this, Laverne Johnson and his colleagues, found that folks who said that they were poor sleepers on the day of enlistment, when looked at 2 years later, it turned out that those folks were less likely to have been promoted, they were less likely to be asked to re-enlist, and generally hadn't done as well. And so a simple questionnaire to just sort of ask, do you have trouble sleeping, was very predictive of how the next few years were going to go. I found a very similar kind of thing in a study at a big international bank in New York. And again, when folks had their admission physical, pre-employment physical, I gave them a short questionnaire that had, among other things, just a simple question: do you have trouble sleeping? Yes or no? And what I found is those folks who answered yes were much less likely to still be employed there when studied at follow-up. So just one simple question could actually predict something about employee longevity. So these are just a couple of examples of the ways that poor sleep can influence a person's life. Next slide, please. Now, I think there may be one right before this one.
Oh,
Whoop.
am I going the wrong way?
One more. Bingo. Okay.
Case and proof of sleep deprivation at its finest, Dr. Walley.
There you are. There you are. Well, one study that came out last year that I found very interesting was they looked at the effect of sleep loss on how couples got along with each other. And they did this by self-report. It wasn't a laboratory study. But what they found, perhaps not surprisingly, is that when both partners slept less, they were much more negative in their relationship. What could have been conversations were more likely to turn out into conflict. And what was very, very interesting was that after conflicts, their bodies could tell a difference. The folks who had had less sleep the previous night had much higher levels of inflammatory chemicals in their blood, which of course are not healthy things to have excessive. So less sleep was associated with not only more negative interaction, but a more negative response of the body to it. Now, again, let me emphasize that this is shortened sleep, which is a little bit different than the topic of insomnia, but it bears on it certainly. Well, let's try the next slide. There we go. This is a very interesting study done this year, and what they found in essence is that sleep loss is associated with social withdrawal and loneliness. Now, let me tell you what this means. First thing they did is that after a night of sleep loss, they found that folks wanted to keep a greater physical distance from other people. They felt more anxious as distance came in. So there's actually a real sense of psychological separation that occurs when you've lost sleep. In another kind of study that went on across time, they had folks type in every day online how much sleep they got and how they felt. And it turned out that on nights where their sleep was more disturbed, the next day they felt more lonely. A very, very striking thing to me. They did some fancy studies with a kind of brain scanning called fMRI. And what they found while doing these studies of the brain was that when you had less sleep the night before, there was an increase in an alarm saying in your brain, in effect, they call it the near space network, saying, hey, he's too close, wanting people to be literally physically further away. So
can I ask you a question about the fMRI, Dr. Walley?
Well, sure.
Do you consider that as a legacy person in this field an accurate indication of someone's sleep in that environment? Do we really know that we're imaging what real sleep looks like in the home? Considering you're in a machine with all the noise and all the sound and everything else that goes along with it?
Well, the sleep deprivation didn't occur in the machine. The sleep deprivation occurred prior to getting into this machine. So there's no sleep deprivation in the machine. These were awake people.
But what I'm saying is the measurement of, so they weren't asleep during the fMRI. They were awake when the study was done?
Absolutely, fully awake.
Okay.
I may not have explained it well, but again, what this is it showed folks after they had not had sleep the night before, the next day, how they responded on an awake MRI.
Cool.
Okay, well, next slide, please. And by the way, I understand exactly where you're coming from. The MRIs are terribly noisy machines, and it would be very, very hard to sleep unless sedated in one of those.
We have people approaching us with a lot of the new innovations and stuff like that, saying they want to validate and correlate what their device does with fMRI. And I'm like, how can you really measure that someone's sleep in a machine like that? It's got to disrupt it to some degree.
Yeah, I would think so. I don't claim to be an expert on fMRI, but certainly the experience I always hear is that it was a very, very noisy situation. Well, I guess moving on, the other point is that insomnia is a risk factor for depression. Folks who have insomnia are much more likely to develop depression subsequently. And there's an interesting and complicated two-way relationship between the two. Because folks with depression, the vast majority, also have trouble sleeping. One of the pioneers in the field named Frederick Snyder said it very well. He said, troubled sleeping causes troubled minds, and troubled minds cause troubled sleep. So there's a complicated and interesting two-way interaction between those two. There's also all sorts of physical medical complaints that have much higher risk in folks with insomnia. This includes high blood pressure, cardiovascular disease, and diabetes. So insomnia takes a big toll on the body, not just in terms of discomfort, but also in terms of your functioning 24 hours a day. I guess on that last slide, if we could just have it for one moment. One more. We got it. Just to mention, as Teresa said, a lot of this discussion about insomnia and its consequences, as well as treatments, is in a book of mine that came out this year called Understanding Sleeping Pills by me, Wallace Mendelson, and it's available on Amazon. A sister book, Understanding Antidepressants, is also available on Amazon. So
that is a subject near and dear to many of our patients and our community's hearts. A lot of people are taking not only sleeping pills, but they're also taking antidepressants, and maybe talking about sort of the effects that they have on our sleep and our brain architecture, both the benefits and the risk from a layman's standpoint would be maybe something we should discuss as well going forward.
Absolutely. Well, that's all the slides I was going to show you, and I'd be happy to chat with you about anything that you like on the topic of consequences of insomnia. Okay,
well, we want to make open up to our participants that are on our Zoom platform and anyone on the Facebook Live platform. Let them know that we are open for questions and happy to pass them on to Dr. Walley and see what we can discuss in this next 40 minutes.
Great.
We have a question from Douglas Urban, and he's asking, are sleeping pills contraindicated for those of us with obstructive sleep apnea?
Okay. Well, let me begin by saying that I'm a psychiatrist and not a pulmonary doctor. So I can give you some general thoughts about this, but the most appropriate ones would be from a pulmonologist. Most sleeping pills do tend to suppress respiration. This goes back quite a ways, but I was one of the first folks to recognize this. At the time, the main sleeping pills were the benzodiazepines or Valium-like drugs, and the most widely used one was a pill called flurazepam or Dalmane. And I wrote a paper about a person who came into the lab with insomnia, and I did a sleep study on him to see if there were any other kind of physiological problems. And it turned out he had, if I remember correctly, about 18 apneas during the night. Well, this was in the very, very early days before folks knew much about sleep apnea. And the textbook, as it were, said that you had to have 30 apneas a night to have sleep apnea. I realize that there have been many, many changes over the last 30 years. But anyway, knowing that, I explained to the patient, well, it looks like you have a little bit of mild trouble breathing, but you don't really have sleep apnea. We're going to go ahead and have you participate in this Dalmain study, but we'll watch you very carefully. And as the next 2 nights went on, we started him on the Dalmain or flurazepam, and his number of apneas shot up through the ceiling. And I think on the second night, he had something like 100 apneas. He began to feel dizzy, sleepy, irritable, and many other things. We quickly stopped the drug, and his apneas returned down to the baseline level. So this was one of the first times that it was recognized that many kinds of sleeping pills can affect respiration. As the years have gone by, there are newer kinds of drugs, of course, the so-called Z drugs, and there are also some new ones that work on entirely different mechanisms, such as Ramelteon and Suvorexant and Doxepin. The newer drugs, particularly Ramelteon, seem to have less effect on respiration, but you have to operate on the assumption that any sleeping pill could potentially affect respiration in a person with pre-existing compromised ventilation, such as folks with COPD or folks with sleep apnea. So the bottom line is that it is probably unwise to use most sleeping pills, at least if there is moderate sleep apnea. I hope that helps.
It helps. I think the way I like to explain it to our community and our population is that sleeping pills are for sedation. They're great for helping you get to sleep if you can't get to sleep. Doesn't mean you're necessarily getting the best kind of sleep from our perspective, but not sleeping at all is not. That's a recipe for disaster and in a short-term death eventually. So we are not anti-sleeping pills. We just want to make sure that you understand the ramifications and the benefits and the risk of using them to help you get to sleep, to figure out what the ultimate end issues might be, whether it's chronic insomnia, an undiagnosed or untreated sleep disorder, breathing, or just a behavioral change, which for a lot of us that are burning the candle on both ends these days, and with the technology and with the current climate, is giving us a lot of reason to be up at night and alone with our thoughts, which is never a good thing, because really at 2, 3 in the morning, our brain should be dreaming and filtering out all those things that we can't make sense of in our conscious life. And when it's not doing that, we're left alone to our thoughts and no one around to stop us from doing harmful things to ourselves or to anybody else. Hope that helps sort of explain my view or perspective on the mix or the correlation of sleeping drugs, whether muscle relaxing components or antidepressants or sedation, because we also have a lot of people now using a lot of cannabis to get to sleep as well at night, and not understanding necessarily the positive or negative impacts that might be causing as well. So there's a lot of self-medicating going on around the world these days, I'm sure you know, and that's why there's such a big boom for insomnia meds to begin with.
Well, I think that's a great point, and I would just mention the way I often say it agrees very much with the first part of what you said, which is that one needs to know the drawbacks as well as the benefits of using sleeping pills, but you also have to remember the risks of not treating insomnia, or the costs of not treating insomnia. And then I guess the other thing I'd add is, of course, there are treatments for insomnia that don't involve medications, that involve psychotherapy, and I'd be happy to chat about those at some point if you'd like.
I think based on our population, for a lot of the newbies who are still learning about this, and a lot of the so-called experienced patients that have made it out on the other side, and then for a lot of those patients that are caught in between, we're still trying to learn how to manage their sleep insomnia, their sleep apnea, whatever that sleep component may be. This is all helpful information because we're not hearing it from our doctors. The 5 minutes we have with them is not enough. Most of the psychotherapists that are clinically practicing are using what they know and what they go by and what they're read up on. So hearing unbiased, clear, matter of fact, expert opinions about what these pills are doing for us and not doing for us is, I think, is so important. It's beyond even explanation at this point. I know for myself, I was taking a preventive, just for my heart medication, statins, and wound up with an allergic reaction. And without understanding that I had an allergic reaction because my blood oxygen was so low, I went on a wild goose chase. So for anybody who's taken any of these meds, if you are not having the reaction that these meds are designed for, you need to look at your blood oxygen before you do anything else drastic or change in your therapy. As a layman, would be my point of advice, if that makes sense.
Yeah, I think that's good advice. And incidentally, I would add one of my motivations in writing this last book about sleeping pills is that for all the reasons you mentioned, folks don't always get a good explanation about both the benefits and risks of taking sleeping pills from their doctors. This can be due to the fact that sessions are so short or many other factors. So one of the reasons I wrote this book is that so that folks who are with insomnia, who are contemplating taking sleeping pills, can learn themselves the important things they need to know, the pros and the cons and the alternatives, so that they're in a better position to be an active partner with the doctor in choosing a treatment. Saying it another way, sleeping pills shouldn't just happen to you. You shouldn't be a passive recipient of a treatment. You should be an active partner making a joint decision with the doctor about your treatment. And the best way to make good decisions about treatment is to be well informed. And that's the kind of motivation I had in writing this book.
We can't thank you enough for writing it, because it's the kind of information that we need as laymen, because obviously we're dealing with, as far as the American Sleep Apnea Association perspective, a syndrome. So depending upon which door you walk through, whether it's the ENT or the psychiatrist or the allergist or the cardiovascular doctor or the endocrinologist or the oncologist or the dementia doctor, or even your primary care physician or your pediatrician, we have a lot of people writing scripts for pills that have an effect on our sleep, good, bad, or indifferent. And not understanding this is not having the whole story. So as much as we all want to take the magic pill and have that silver bullet, it's not realistic and it's not practical. We have to start to look at our body consciously and unconsciously as a whole. And we have to make sure that sleep component, whether medicated or not, is incorporated into that equation.
Well, I think you just said something very important, by the way, when you talked about the desire for a magic bullet. And let me just elaborate on that for 1 second, because I think you hit the nail on the head. The suffering from insomnia is so great that it's only natural to want something that's going to make it go away instantly, that's going to make you feel better immediately. And that feeling is absolutely natural and understandable, but it's also important to realize that it's not realistic. These are treatments that by and large will help, and they will help to some degree, but none of them are the kind of thing where the next night or the next few nights, suddenly the whole world has changed. You work with a doctor or a therapist on an ongoing basis. You may need a different medicine. You may need to go back and rethink the whole situation to see whether, for instance, you're also depressed and might need treatment for that. in any event, treating insomnia takes time, and it's really important to have realistic expectations and not to expect too much too fast. And not, likewise, it's very important not to give up, because treatment is out there. They're mostly successful, but they do sometimes, in fact, often take time.
Can you talk a little bit about the CBTI world and what it is, and sort of in plain English, explain to our community how that component, how important and vital that component is to all of our sleep, whether sleep with a sleep disorder or not?
Absolutely. And by the way, well, first, 2 points. The first is that it's really important to remember that sleeping pills are only one kind of treatment for insomnia. And another very important kind is non-medicine psychological treatments. And the second point I want to make about that is that they're particularly useful for folks who have sleep disturbance with sleep apnea, for the reason that we just mentioned, which is that the possible interaction of sleeping pills with sleep apnea. So this forum today from the Sleep Apnea Association is a very, very appropriate forum to talk about non-medicine treatments. Now, the single treatment that's by far the best documented for treating insomnia is known as cognitive behavioral therapy for insomnia, or CBTI. It's a kind of treatment that recognizes that insomnia has many, many different facets. So it correspondingly has many different components to the treatment. And let me mention, before I talk about some of those components, that folks hear the word psychotherapy and they say, oh my gosh, I don't want to get into that. And they have images of, old Woody Allen movies where you go 4 or 5 times a week for years and you're never quite sure whether it benefited you. CBT is not like that. CBT is something that usually involves anywhere from a total of 6 to 10 visits taking place over 2 or 3 months. It's a very short-term kind of therapy. Well, I mentioned before that it has a number of components. Let's look at just a couple of those to give a flavor of them. The first one is known as sleep hygiene, which is a kind of a catch-all phrase for useful advice about sleep. There are many of these. Some are very obvious, like watching your caffeine intake, and others would include getting moderate exercise, preferably in late afternoon or early evening, because later in the evening it can disturb sleep. Many other kinds of things of that nature. Now, the thing to remember about sleep hygiene is that it's a set of helpful recommendations, but it's rarely successful all by itself. It should be viewed as a starting point when you go on to other specific kinds of treatments. Now, there's many of these, and we'll just mention a couple to give the flavor of it. One of them involves the idea that folks begin to associate the place they sleep, the bedroom, with behaviors that are incompatible with sleep. So the recommendation of this kind of treatment is strip the bedroom of all behaviors except sleep. So by that I mean don't pay your bills in the bedroom. Don't have discussions with your spouse about the state of your marriage. Bedroom. Remove all activities from the bedroom except sleep and loving.
So I guess I'm the biggest hypocrite here, because my office is in my bedroom, as you can see behind me, and my wife and I work together. And especially when our daughter was away this summer for Sleepaway Camp, we wound up realizing that we were talking about work first thing in the morning and last thing before we went to bed, and it wasn't healthy. And so what we actually have an interview with Dr. Grandner from the University of Arizona that we're going to release out soon, talking about some of the new innovation that's going on with some of the CBTI therapies in real time, and working that into whether it's our next version of our sleep health app that's on the Apple Store, and then the Android version. But really starting to, you know, yes, we want to have the 6 visits with the psychologist or the psychotherapist, but we also know that that's not enough, that this is a long-term behavioral change, and we need to give more immediate feedback on what you're doing right and what you're doing wrong with it. So you can measure, you know, maybe starting today, you're getting 6 hours of total sleep, but if by doing CBTI, there's a good chance you could add an extra 60 minutes of total sleep, which would really change the outcome and the quality of life that you'd see, and you'd notice it, because everybody knows the difference between a good night's sleep and a bad night's sleep when they do get it.
It's absolutely true, and I've always been struck at how successful CBT treatment very often is. There's other kinds of pieces to CBT. Another one, which is a little harder to explain, is what they call sleep restriction therapy, and what that is based on is the observation that folks with insomnia, when they're not getting very much sleep, they tend to stay in bed much longer. And the result of this can be very inefficient sleep. So and this can prolong the sleep difficulty. So what sleep restriction is about is you have a person keep a diary for a couple weeks and measure how many hours of sleep they were in bed, or let me say it again, how many hours they were in bed and how many hours they think it was actually sleep.
Right.
So I'm making these numbers up, but let's say a person turned out that said on average they're in bed 8.5 hours. See, it's a little bit long, but they were sleeping 5 hours. Well, what you then do is have the person stay in bed only 5 hours, and very, very quickly their sleep will become efficient because there's not much time for it. Then when they're sleeping most of that 5 hours, you increase it to 5.5 hours. Then when they're sleeping all of that, 6 hours, 6.5, and so on. So it sounds a little paradoxical, but it actually can help get rid of one of the perpetuating factors of insomnia, which is staying in bed much too long while sleeping poorly. Another part of CBT is the cognitive part, which involves ideas about sleep that may not be helpful to you, and reviewing these kind of ideas. This is adapted from a earlier kind of CBT, which is also very, very potent and very well accepted, which is CBT for depression, where it was found that folks with depression can have ideas that are about sleep or about depression that aren't very helpful. So applying this to sleep, one's attitudes toward sleep, one's beliefs are reviewed and considered, and some ideas that may not be so helpful are rethought and reframed. There's other components, excuse me, of CBT. Another that's more new is meditation, which it turns out can be a useful part. So there's a number of different things, and these are presented as a package and then tailored for the individual person or individual couple's situation. And very often,
it's funny you say that, Dr. Ben. I don't mean to cut you off, but my daughter actually at 10 years old, almost 11, goes on sleepovers with her friends. She'll take her CPAP with her because she knows that gives her, if she puts her mask on, it engages that diaphragm, and it helps her relax and fall to sleep in a foreign environment where she's not usually, it's not her own bed. Yeah. And at almost 11 years old, she's conscious and cognitive enough to know that, hey, I want to go over to my friends and have a sleepover, but I also know I need to get a good night's sleep, and this is going to help me get to sleep. For her, it's a device. Hopefully she won't need that as she gets older, as we expand her airway. But for other people, you know, you know, there was the classic, you know, nightcap. I mean, that was how much has that been portrayed in literature and movies and TV? You got to have a nightcap before you go to sleep. And just that glass of wine or that alcohol as a sedative and as a muscle relaxing component, it's really doing you more harm in the long run than doing you good. Yeah, it might get you to sleep, but you're not sleeping well when you're under that, theoretically.
Well, boy, you hit the nail on the head with that one. Why don't we just talk for one moment about the topic of alcohol and sleep, because what you said is so important. Loads of folks do take some alcohol before going to bed in an effort to sleep better. And it turns out that's the worst possible thing you could do. That's a couple of reasons for this. If you're somebody who's not addicted to alcohol, you're just, you know, an occasional user, taking some alcohol before bed will help you go to sleep. The problem is that alcohol is broken down by the body so rapidly that you have a kind of mini withdrawal syndrome the same night you took it. And any small benefit you may have gotten at the beginning of the night, you pay the price in the second half of the night by having a kind of very, very disturbed sleep with loads of awakenings. So alcohol is not a good answer for helping you sleep. And incidentally, and I'm sure this is something that the American Sleep Apnea Association has talked about many times, I'm sure. The other issue, of course, is that alcohol is a respiratory depressant and can make sleep apnea much worse.
Yeah, it's something we talk about, but it's like one of those broken records. We have to keep saying it because sometimes people don't hear it, or they're not ready to hear it. Or we have to, you know, as the literature says, we have to say it multiple times before it starts to sink in. That's one of the reasons why we're doing a community forum like we're doing today for Sleeptember with an expert in the field who's, you know, seen it all and been around and can call BS when you see it. Because there's a lot of misinformation and not up-to-date information that's out on the internets or on the so-called Dr. Google. So, you know, our job as a patient advocacy association is to make sure that the right information is getting out there, the up-to-date information is getting out there, and that we can really clarify between, you know, what's theory and what's real and what's not. And, you know, this conversation is a good transition to really get into the cannabis conversation, because I think it's really starting to take hold around this country. We know it is by state, and people are really starting to make the move, knowing that the long-term effects of the benzos and the trazodone. I couldn't believe when we found out that trazodone was the most prescribed medicine for sleep in all of America. And Carl Stepnowski, our chief science officer, explained to me it's probably the most diagnosed medication in geriatric and assisted living facilities. And that's a scary thought when people think about that and what that really means.
Indeed. Trazodone is a good example of an important aspect of insomnia treatment, and that is that many folks take medicines that are not indicated by the U.S. Food and Drug Administration for sleep. The fancy term indication just means that the FDA has seen studies that show that a medicine is effective for a particular purpose and says that it can be marketed for that purpose. When doctors prescribe medicines that aren't indicated, that's called off-label prescribing. And it's perfectly legal and often done. But it's important to remember that when you're getting a medicine off-label, it probably hasn't been tested as thoroughly for the specific use that you're giving it to.
Which my favorite thing is that, you know, it's being someone with a fibromyalgia before I was ever dealing with my sleep apnea or any of my other issues. The go-to that I see that I was prescribed and that I see a lot of other people prescribed is the Neurontin, which is the anti-seizure nerve blocker. which is made for people with obviously seizures, but it's being prescribed off label, as you said, for everything under the sun in the umbrella. My cat agreed with my statement. She wanted, if you heard her.
Well, off-label prescribing is very common practice, and there are very often reasons to do it. But it's always important to remember the medicine you're taking may not have been tested as thoroughly. And incidentally, not talking specifically about sleep, but just talking about off-label prescribing across the board for any purpose. There was one very interesting study that showed that when medicines are prescribed off labels, there's about a 40% greater chance of having side effects than medicines that are prescribed on label.
Wow.
So it's always something to keep in mind when you're talking about off-label medicines for sleep.
Wow. We have a question here from Joelle Dobrow, who is one of our panelists at our FDA Awake Sleep Apnea Initiative meeting that we did in this past June. And Joelle asked, what about CBD or THC products with marijuana derivatives? So a lot of people are taking the cannabinoid oils and other things right now. What are you seeing, or what is the literature saying, or what do we need to see in research to sort of validate or clarify what's the benefit risk for our populations?
Yeah. Well, it's a great and very important question, because many people are using various cannabinoid-related substances to help them sleep. I feel badly, but I'm going to have to take a pass on this one, just because I'm not as familiar with the scientific literature about it. What I can tell you is that a lot of researchers are interested in it and are pursuing this very actively, and it's something we really need to watch as the next few years go by and these things come out. But I feel badly, but I better take a pass in terms of what I personally know about it.
That's quite all right. I didn't mean to put you on the spot. We know that the science and you know what I was trying to point out is that there's a lot of research still to be done the right way, but we haven't seen that. Teresa, you're back with us.
Yeah. My phone was acting crazy.
That's okay. Do you have any questions for Dr. Walley, since I've been taking up all the airtime?
No, I think that we pretty much covered everything that I had, and I wanted to be sure and ask Joelle's question. But you know, that is just very new. Everything is very new with the marijuana derivatives. So it's best to talk with your own doctor about those things, I think.
Well, you can see the generation between the panelists here and and me. You know, in the old days, it used to be go to your doctor and ask them, and not that I have a problem with that, but especially for a lot of us with chronic diseases, the doctor doesn't have time. We're used to talk to the nurse practitioner, and quite honestly, since it's technically federally illegal, the doctor is never going to tell you anything, but it's an illegal, you know, drug that you shouldn't be using at this point, because the science isn't there. But I also like to point out we have such an opioid epidemic crisis going on right now that, for me, and my personal belief is that the long-term ramifications of that compared to the cannabis or any of the derivatives that come out of it, I think are a lot worse, especially with the benzos and the propensity for how much that's being prescribed all over this country, especially in certain populations in our country. I think just seeing people who are coming off of these, who've been on it long term, when they tell you it's worse to detox off benzos than it is heroin, that's a scary, scary thought for society, because we have a lot of walking benzo addicts around that don't even realize it. And the day is going to come where they're going to really need to get that out of their blood system, unfortunately. And it's not going to be a fun road.
Well, you know, when I used to be a smoker of cigarettes, and it was, I used to hear that it was harder to get off of nicotine than it would be to get off heroin, and I totally believed that, and that was one of my excuses, I think, for smoking for so long. And I finally stopped, and and now I'm a believer that I should have never started at all. But I think that you're right. The benzo epidemic is just unbelievable.
Well, I like to tell people, if you're presenting with anxiety or depression and you haven't done a full, complete sleep workup to know what's going on biologically with your sleep, let alone psychologically, you don't have the whole story. So before any pills are written, unless you really need to get sleep and you haven't slept in a week and you're about to lose your mind, we really need to look at the whole picture. And, we believe, listen, I'll be on an SSR1 the rest of my life. Because I was sleep deprived for 35 years, my brain architecture was fragmented.
Yeah.
Being on Prozac helped me rewire my brain and helped me get 100% compliant with my CPAP therapy for the last 10 years.
Yeah.
Now, do I still have residual anxiety? Of course. I was, self-suffocated for 35 years.
Sure.
Someone stuck a pillow over my face and took it off. Not somebody. I did it unconsciously my entire life.
Yeah.
So some of these things are reversible. Some of them are not, and you got to learn to help manage them. But the truth is, if I would have presented to the wrong psychiatrist or psychologist, with anxiety, most would have written me a prescription for Ativan or Xanax, not knowing that would have made my sleep disorder breathing, my sleep apnea, worse because of the muscle relaxing component. And just that knowledge and education for us to get that out there as the American Sleep Apnea Association is vital and crucial, because people don't realize you might be making the sleep worse by treating the anxiety or depression.
Yeah.
And that has terrible ramifications.
Well, just to amplify a couple of things that you said, going back, Teresa, to comment about smoking, I would mention another aspect of smoking, by the way, is that there's some components of cigarette smoke that stimulate the liver to break down medicines at different rates. So a whole nother aspect of smoking can be its effects on liver metabolism and other medicines you're taking. Adam, you're talking about the opioid. I would just mention a very, very interesting study just came out recently on long-term use, not necessarily abuse, but long-term use of opioids has been associated with 24-hour-a-day fatigue, poor sleep, daytime sleepiness, decreased functioning, and depression. So opioids can have profound effects on your whole life. And finally, I know that, again, this is something that your association has said often and should continue to say often, that opioids, of course, are very, very powerful respiratory depressants, as I'm sure you've said.
We say it, and we have to keep on saying it until it's a broken record, until we don't have to say it anymore. I mean, it took 50 years before people started to understand what the cigarettes were doing to their bodies long term, and it's unfortunately, we've created this epidemic, and it's just like with the methamphetamine. We could eliminate that. There's only 8 labs in the world that actually produce the product that's needed for it. But as a society, we want to treat the symptom. We don't ever want to get to the root cause, which is the antithesis of what the American Sleep Apnea Association is about. Not that we think everyone has sleep apnea. We just want to make sure that they have the whole story, that they have the sleep component factored in to their life, to their family's life, to their children's life, to their parents' life, and how it's affecting them in the home, at school, in the workplace, and in their social life. I mean, we know that the insulation and the depression and the self-isolation is a tangible, noticeable metric that we can look at for people that are not performing or functioning well. And it appears to be pandemic across society, because you see what's being advertised late at night on TV. You see what's driving it from a business standpoint. And, I come back to, we have sleep is a denial. People love to say, I'm going to die in my sleep. And that's great. And if that's the way you go, we're all going to die at some point. Maybe you're lucky, but truth of the matter is, it usually isn't so lucky. You usually have a stroke, a cardiac event, and you don't necessarily, it's not such a pretty way to go out. So saying all that, you know, it's my way of saying that, you know, all we want to do is get the education out there. We want the sleep doctors to understand it. We want them to know that this badge of honor of working 24 hours on, or as they used to do in med school, you know, how much you could do on as little sleep. It's not a badge of honor. This is the antithesis of what we want as a society. We're seeing rash and irrational decision making playing out in front of us every day, just in society right now. With what's going on, and you can literally, you know, look at the timestamps of certain tweets and realize, you know, the people are not functioning with full mental wherewithal right now, and that's not good, because those people are in charge. They're running the buses, they're running the nuclear labs, they're running the power plants, they're flying the airplanes, they're driving the trains, they're driving the long freight trucks cross country. They're mom and dad burning the candle on both wheels, picking up their kid, taking them to and from different activities. It's a pandemic issue of a society of zombies that don't even realize it right now, and are on some sort of medication, good, bad, or indifferent, and not understanding the long-term ramifications of that. I'll get off my soapbox for now.
Well, it's a good soapbox, and I think these are great points you're making, and I wish you and the association well in pursuing this really important work.
Thank you, Dr. Mendelson. We're so happy that you're able to join us, and we hope that everyone can go out and buy your book. It is definitely comes from a man who knows what he's talking about. If anybody's ever read Dr. Mendelson's CV, they will know that he is well-versed and has got the background to back up exactly what he's saying. So this isn't just me coming out of a layman's mouth. This is coming from one of the world-leading experts, and we invite you to come back to discuss any and all things about sleep anytime you want, Dr. Mendelson.
I'd like that very much. Thank you.
Teresa, you have any parting words for us as the grandmother of our association?
I just wanted to thank you so much, Dr. Mendelson. This has been such a pleasure, and I've known you for so long that, you know, this is sort of I never thought this kind of thing could ever happen, but look at technology. We're here live on Facebook. We're live on, you know, be able to record on Zoom, and I'm just so happy that I was here for it with you.
Well, I was too, and I've enjoyed it, and I'd be happy to find some other topics that we could talk about in the future.
Love it.
I'm sure we can. We're glad to invite you back, even as just a panelist and as a key opinion leader and expert in your field to chime in when necessary and when appropriate. So thank you so much, and have a good day and sleep well.
Thank you. Bye.
Bye.